Thank you. I have no disclosure. First, I would like to thank Dr. Ramaiah for the invitation to talk about the art of sclerotherapy. The first question that came to my mind, is it really an art? And sometimes it is, I think, such as particularly when it's performed for cosmetic reasons. Then you really want to be like an artist, skilled at making the legs become beautiful or more beautiful than prior to that. But what is sclerotherapy? Is the treatment of varicose veins by injection of a chemical solution which causes inflammation and contraction of the vessel wall with coagulation of the blood vessels. As a result, the veins fade away within a few weeks or months. The use of sclerotherapy has gained popularity since it was introduced in the 1930s. And 20 years later, the development of foam sclerotherapy has revolutionized the treatment of varicose veins. Dr. John Bergen was used to say that foam is the future of varicose vein treatments, and his predictions were correct. Indeed, today, sclerotherapy can be used as the primary method of treatment for almost every aspect of the superficial venous system. We can use it to treat incompetent saphenous vein, particularly with the introduction of Varitena. We'll have the privilege to hear Dr. Walker discuss the applications. And with the physician compounded foam, we typically treat the tributary varicose veins in the office. We can use it for the perforating veins. It has a role in the treatment of venous ulcers, even the varicose veins of pelvic origin, and of course in the treatment of reticular veins, telangiectasia, and spider veins, for which it is better known. So it is surprising to me that sclerotherapy is not given a more importance in the training of vascular specialists. It should not be reserved to those interested in phlebology or dermatophlebology, because it actually can be used to manage every aspect, as said, of the superficial venous system. There are two commonly approved, FDA-approved sclerosing agents, the sodium tetradecyl sulfate, the STS, and the polidocanol, introduced 20 years later. There are other sclerosants used in common practice, such as hypertonic saline and glycerin. And the foam sclerotherapy is more effective because it's 3 to 4 times more potent than the liquid form. The polidocanol foam is now, as Dr. Golshan told us, and it's commercially available under the name of Varitena. And in the office, we use the physician compounded foam that I would show over here. No need for specialized equipment. You take 2 5cc syringe connected by a 3-way stopcock, and the best ratio seems to be the 1-to-4 ratio, 1 cc of sclerosant and 4 cc of air, and the mixture produces a dense, creamy foam ready to use, but you have to use it quickly. The foam also has the advantage of being visualized under ultrasound, so you can actually direct the therapy. Dr. Goldman provided us with this algorithm. There are other ones, but it is important to have an algorithm, especially when used for medical necessity, because the higher the concentration, the higher the risk of staining, hyperpigmentation, and ulcerations. When I use it for cosmetic purposes, I found the use of an algorithm quite difficult, and because there are so many variables, the skin texture, the color of the skin, so in general, that's where I think the artist comes into play. You have to use it at a very low concentration and often in combination with transcutaneous laser, for example. So is the success of sclerotherapy today is due to introduction of new devices? Not really. The duplex ultrasound has been in use for quite some time. We use it for treatment planning and execution with high-frequency transducers. There are transillumination devices that help to identify the feeding reticular veins, but I use the vein light, but not all the time. And the near-infrared technology is available, but only at a few facilities. So the duplex ultrasound is really the imaging modality of choice. The cannulation of the varicose vein can be performed in an ultrasound. And again, you actually can follow the foam during the treatment. and avoid the foam to go into the healthy veins and the perforators, and you really want to avoid to go into the deep venous system. I like to use butterfly needles secured to the skin with steri-strips, and this way I can free my hands, and using the probe I can direct the foam into the tributaries. So with one injection, this allows to treat more varicose veins, and also it allows us to avoid going into the deep system or to go into the healthy veins, just using compression. For sclerotherapy of reticular veins and spider veins, we generally use a straight needle and low concentration of either foam or liquid sclerosant. For the reticular veins, it's common to use the foam, but for the spider veins, personally, I prefer to use the liquid form to avoid staining and pigmentation. The patient is asked to return 1 to 2 weeks later, and if there are thrombus present, such as here, it can be evacuated. Clot extraction can be performed with an 18-gauge needle. This to avoid hyperpigmentation. So in summary, most varicose veins and spider veins can be treated by sclerotherapy, regardless if it is performed for medical necessity or for cosmetic reasons. It is important to achieve a good aesthetic result. Proper knowledge of the anatomy of the superficial and deep venous system is important. The ability of the clinician to perform the examination, to be able to interrogate the saphenous vein, the tributaries, the perforators, and as well as the subdermal plexus and the reticular veins when there is a high-frequency probe available. This is essential. It is important to have a treatment strategy, and Dr. Glovitsky will remind us of the clinical practice guidelines. They're quite helpful. For cosmetic sclerotherapy, to me, it's a different animal. It requires a combination of knowledge and different skills and experience. In this case, for example, I use a 0.1% of liquid STS and combined with transcutaneous laser, and the photo on the right was obtained 1 year later. So you can see it's still pretty good. So I don't know if we have time for this, but the key factor to contribute to the success of cosmetic sclerotherapy, the duplex ultrasound allows to better treatment planning and also identification of the feeder reticular veins. It's important to treat them prior to treating the spider veins. It's important to, and critical actually, to have the optimal concentration of sclerosant, foam or non-foam, to minimize the risk of complication. There are a variety of techniques available. Dr. Bush in Florida emphasized the benefits of tumescence-assisted sclerotherapy. I haven't tried it yet, but I will. As said, it's important to remove the thrombus after sclerotherapy to avoid pigmentation. And finally, the skills of the operator. There is, especially for cosmetic, there is a steep learning curve. Thank you very much.